I would like to start by thanking Chip and his co-chair for this fantastic meeting. So what I'll try to do in this, 10 minutes is to go through this all. But so as an example for an Eastern Mediterranean ancestry, I will talk about our experience mainly with the 25 patients we have, and I will briefly touch upon the existing papers from the area. But I did hear that our friends from Israel are about to publish 50 patients, but I don't have data on that. So maybe they can comment afterwards. So the leader in futures, because we have a lot of G47R probably, is polyarteritis nodosa-like futures. And we have the other futures that you all know about. And unfortunately, we have a high consanguinity rate, and that's one of the reasons for having a lot of patients, I guess. So our pathologist is a very experienced one, but she cannot differentiate between a classical polyarteritis nodosa and DADA2 deficiency. So you have to suspect it with other futures. In the 15 polyarteritis nodosa-like patients we have, they all had the very typical pathology or the very typical aneurysms that you would see in a classical PAN patient. So these are some of the, and you all know these findings, and they do have neurological features as well, but it's not the presenting feature. As to the demographics, we pediatricians are better in diagnosing it, but as you can see, the delay in diagnosis was, the pointer is not working, I think. In adults, it was quite high, but this was mainly because, these patients were diagnosed after 2014, and they were followed. Yeah, no, I found it.
Oh, you found
actually,
it.
yeah, it is. It's not working great. Okay, so. This one?
So it's the thing right at the top.
Okay, perfect. So the age at symptom onset is in childhood in almost all of them. Okay, I'm not, but yeah, okay. So, but in adults, these adults were diagnosed after 2014, and they had been followed up with other diagnoses, and that's why this delay in diagnosis is quite high in these 6 patients that I'm showing to you. So these are the findings we have in our polyarteritis nodosa-like patients. Of course, they all have the skin findings. They all have GI findings, and this is something that stands out in many of the publications from the area. They do have neurological findings that I will come back to. Renal findings are there, and I will come back to that as well. There are a lot of eye findings, and unfortunately, the consanguinity rate is high, and it's, of course, as expected, higher in this group as well. Now, the neurological features we have range from peripheral neuropathy to core myopathy, etc. There are patients with stroke, but it's not the presenting symptom, although one of them did describe stroke before he presented to us with a polyarteritis nodosa-like feature. One of our patients, interestingly, had spinal atrophy, and I don't think this was reported before. And they had a lot of features related to their eye as well. So why is stroke less frequent in our hands? Actually, 2 of our 15 patients, as I said, had stroke before they came to us. It's maybe because of the lack of awareness among the neurologists and maybe epigenetic factors. But when we looked back with our pediatric neurologists to their huge childhood stroke registry, we did find 6 patients who had consanguineous parents and had a very early age. So we're going to go back and look at them. So maybe it's going to increase. So the unusual features we have seen, these were actually 2 of them were adults, and these were the ones who died actually. So this one with focal segmental glomerulosclerosis, collapsing variant, he died in his late 20s. And there was one patient who developed renal amyloidosis nodosus. So I guess this reflects that the inflammation these patients have, and indeed they can develop the very severe sequela of inflammation if you don't treat them. Maybe some of the renal amyloidosis patients who we thought had FMF maybe had DADA2 because, you know, we have had patients referred to us with an initial diagnosis of FMF. Other unusual features we have seen are, like there was one patient who came with a very severe cardiac disease, very severe myocarditis, impaired myocardial function. We had one patient who developed hemophagocytosis, so I was interested to hear that, you know, it was expressed in NK cells as well. And we had a patient who developed myelofibrosis. And we had one patient, yes, oh, okay. So, and apart from these 15 patients who presented with polyarteritis nodosa, we've had 10 patients who presented mainly with hematological findings, and I will quickly go over them. They also had, one of them also had an ischemic stroke in his history, but mainly they presented with red blood cell aplasia. Some of them had skin features, a few the livedo, but it wasn't striking. The main feature was really a Diamond-Blackfan-like anemia. Although they differed from Diamond-Blackfan anemia in that they presented earlier, they had normal cytic anemia, normal ADA levels, but low ADA2 levels, and no congenital malformations. As I said, a few of them did have other accompanying features. So our colleagues in hematology also presented this recently. When we look at other publications from the area, of course, there's the one from our colleagues from Israel, and this is from my colleagues in Istanbul, where they again show that skin manifestations are quite obvious, and a lot of them had GI inflammation. Actually, one of their patients died, 2 died, I think, and 1 died due to the perforation on the GI system. So the main clinical differences in Turkey seem to be that vasculitis predominates, mainly because of the G47R, and this is true for Israel as well, especially with the Georgian Jewish population. Death was, in our series, was to necrotizing pneumonia, and the other was probably due to the kidney disease, and death was due to intestinal perforation in one and cerebral bleeding in another, so maybe more severe disease in our area. The diagnosis, we believe we also need ADA enzyme activity to confirm the diagnosis, and we've been doing this from the start, along with mutation testing with a spectrophotometric method. And we do have one heterozygote who presented with the phenotype, and we have found only one mutation, but he had very low levels of ADA2, whereas the polyarteritis nodosa patients who do not have ADA2 mutations have a normal ADA2 level and controls as well. So the polyarteritis nodosa patients have normal levels, whereas the DADA2 patients and the ones with hematological features also have low levels. As to the mutations, all of those with a polyarteritis nodosa phenotype had at least one G47R affecting the dimerization domain of the enzyme, whereas those that presented with mainly hematological phenotype had various mutations that affected the catalytic domain of the enzyme. And these are the mutations we've had in our 25 patients. Of course, G47R is the leading one. This is once again. And these are publications from the area. So Georgian Jewish patients, of course, have a 1 in 10 carrier rate, so it's very high there, and it's high in the other one as well. There was another paper describing a patient with neutropenia that had another mutation. This was from the region as well. And then there was one patient with a lymphoproliferative syndrome, again had G47R, and it was from the Middle East, report from the Middle East. So, and I must say that in our patients with hematological features, maybe an answer to Ivona's question, we did try anti-TNF for 2 of them before they were transplanted for bone marrow transplantation. One of them was given anti-TNF for a very short time, so I won't be able to comment on that. But for the second patient, when we first started anti-TNF, the neutropenia, slightly increased, but then she was down again with a profound pancytopenia. And again, in the end, she had to receive hematopoietic stem cell transplantation. So whenever we have diamond black film-like anemia in DADA2 patients, we suggest bone marrow transplantation. So to conclude, we have a lot of polyarthritis nodosa-like patients in the region, probably because of this G47R high rate. We have other features as well, and when we have these other features, we see other mutations in the DADA2. We believe that the enzyme activity should be measured because of the examples Marco showed and because of our heterozygote patients. We think stroke is not less frequent. Maybe it's awareness, and the differences may not be explained by mutation alone. Okay, I'm finished.